Okay, good morning, everybody. I'd like to call this meeting of our task force together, the Manteo Task Force. And I'm going to stray a little bit from the agenda. We have some elected officials here today, and I'd like to introduce some of them. Senator Sanderson is in the room. Senator Bobby Hatt is in the room. Soon to be Representative Paul O'Neill is in the room. Sherry Wickstrom is in the room. Irvin Bateman, County Commissioner, is in the room. Bob Ross. There's Bob in the back. Let's see. Ben Kuhn, I think I saw him come in. Mayor of Nags Head, thank you, Ben, for being here. Have I missed any elected official?
Yes.
John Lindley.
Todd? Yep. Thanks for being here. I want to say my good friend Terry Wheeler, former county manager, is with us today. So knowing that any politician that gets in front of a crowd likes to speak sometimes. So I don't know if there's any of y'all that would like to speak at this time, but I'm going to allow y'all that opportunity to do so now. So if anybody would like to share any words, an elected official, please do so now. Come to the podium. Okay.
Thank you, Malcolm. Just very briefly, I know how critical a problem this is. For the last 90 days myself, I have been looking for a primary care facility because my doctor left town. And you can't find doctors. They're very scared. Will even consider taking new patients at this time. And so this is something that, people like to use our Constitution to front a lot of things. But this is one of those things that I really, truly believe our Constitution guarantees us when it talks about life, liberty, and the pursuit of happiness. And we need to do everything we can to provide this kind of service to our citizens. Thank you.
Thank you, sir. Anybody else? Any other elected official? Okay. I'd also like to recognize coming in a little bit late is former clerk of court Betty Mann. As a public. All right. Could I have a motion to adopt the agenda?
So moved.
Second.
All approved?
Aye.
Okay, thank you. Has everybody seen the minutes of the meeting, prior meeting? Is there a motion to approve that?
So moved.
Okay,
Second.
all in favor?
Aye.
Okay. The next thing is the presentation from the hospital and the Dare County Health Department on the community health care needs assessment. And before we do that, I'd like to say a word or two about what is going on in healthcare over the last couple of years. We were in our generation, I believe, and many of y'all's, an unprecedented time with the pandemic. The hospital, our healthcare providers, their staff, long-term care providers did a heroic job in serving our community. Long hours, difficult circumstances, a pandemic they really didn't know what it was or wasn't. Sheila, Tess, Amy, y'all's organizations should be applauded for the job that you did. And I know that everybody in this room thanks you for the job that y'all did. So in saying that, would y'all, the floor is yours.
Okay, Amy, if you want to start.
Absolutely. Thank you, Malcolm. I'm really pleased today because I think this is the largest crowd we've ever had the opportunity to speak before about the results of our community health needs assessment. The very first community health needs assessment was conducted here in Dare County 20 years ago in 2002. At that time, my position in Dare County, I was the health education supervisor at the Dare County Department of Public Health. And we did conduct the very first community health needs assessment in partnership with the Healthy Carolinians Initiative with the state of North Carolina. The results of that assessment really haven't changed much over the years, although we've made great strides and made a big difference in Dare County. That first assessment resulted in 3 priorities being selected as health issues or opportunities in our community. And those were access to health care, motor vehicle injuries, and substance abuse. Things that came out of that very first assessment 20 years ago, the Community Care Clinic of Dare, our free clinic for the uninsured and underinsured in Dare County, was formed from that first assessment. The grants were written in partnership by the Outer Banks Hospital as well as the health department. So our partnership has a long-standing history of doing great things in this community. As well, currently, the Outer Banks Hospital pays the salary and the benefits of the executive director of the Community Care Clinic of Dare. Something else that came out of that first assessment was the formation of the Coalition Against Substance Abuse, otherwise known as Dare CASA. Some people in this audience may have participated in that organization, making a big difference in this community in terms of the substance abuse issue. As well, in more recent years, something very positive that has come from more recent community health assessments as the priorities have changed a little bit. I will say that access to health care has been identified every assessment. But over the years, issues of aging has also been identified as a community health priority. And something that has recently formed from that being identified is a nonprofit around the issue of dementia and Alzheimer's. The Dementia Task Force now has its own nonprofit. And in recent years, the Outer Banks Hospital was named the first dementia-friendly hospital in the state of North Carolina. So much work has been done in this community around community health needs assessment and then action items and actions taken to make this community a healthier place to live with a higher quality of life. I'll also note, Malcolm brought up the pandemic. Right before the pandemic hit, based on the 2019 Community Health Needs Assessment, there was an active access to healthcare work group ongoing in this community, and it was being chaired by the president of the Outer Banks Hospital, Ronnie Sloan. The task force had a few meetings, and then the last meeting was held on February 4th, 2020, and you know what happened a couple weeks after that. And so that task force work got taken over by the work to fight the global pandemic, COVID-19. So thank you all. I'm just so pleased. We've presented the Community Health Needs Assessment over the years to many groups. We've had events, we've been to the chamber, but never have we had quite this level of audience and interest. And that's very energizing this morning. So thank you.
Thank you. And Matt, will you be able to advance the slides as I progress? Or do you want, would you prefer? The only thing, if I go to the podium, my back, I don't know how you prefer. Okay, great, thank you. Well, good morning. I will walk us through what is basically about 15 slides. Maybe I'll stand to some of you, but I don't, can you hear me if I'm not right in front of the microphone? Okay, that way you're not blocked there. You all can't hear me? Oh, they're saying yes. Okay, I'll try to make sure I enunciate. So what I'm going to share today is about 15 slides trying to cover the entire Community Health Needs Assessment, which is a 280-page document. We do this in partnership with Public Health and the hospital. Thank you, Dorothy. Thank you. There we go. The IRS requires nonprofit hospitals to conduct a community health needs assessment every 3 years. Public health has a requirement to conduct a community health needs assessment every 4 years. A number of years ago, we decided to reduce the time frame for public health so we could partner with the hospital and work together on this project. It would be silly for us both to be doing community health needs assessment. So we now do one in Dare County every 3 years. It's a comprehensive assessment at looking at the health needs, the health successes, the health gaps. And when I'm talking about health, I'm talking about total health for individuals. So this particular community health needs assessment, we can move to the second slide, is the second of a regional effort. Starting with the previous health assessment that was done 3 years prior, the eastern region of North Carolina said, you know what, let's get together and make this a larger collaborative effort so we can then share data, compare data across eastern North Carolina as well as the state. We used to only make comparisons between Dare County and what was called like a sister county somewhere across the state that someone selected. And it always didn't necessarily provide the best comparison. So now by doing a regional approach, we're able to make really solid comparisons to what's happening with the health and well-being in Dare County compared to other counties. So there are 33 counties that participate in the regional effort. And when you conduct a community health needs assessment, you first look at primary data and secondary data. Primary data is gathered through surveys, which we collected 1,029 surveys from individuals with a standardized list of questions. These same questions were taken across the entire region. And then we held focus groups. And so we got interviews, personal interviews, and one particular focus group was held with 12 mental health practitioners. So that's the gathering of the primary data. So hearing directly from individuals what they feel are the most pressing health needs in our community and the most successful items that are going on in our community. In addition to health, it also looks at, we look at demographics, we look at the services that are in the community, and we'll go through some of that in these slides. Also, what's collected is secondary data. That's the data that you're pulling from the CDC. It's statistical data. You're looking at health rankings. So that's the quantitative data versus the qualitative data is what you're gathering in your focus groups and your primary data. Once all of that data is compiled, and that's really what mostly comprises the 280 pages of the Community Health Needs Assessment is all of that raw data. Then the Healthy Carolinians of the Outer Banks, and that's a coalition of, many stakeholders. I think we have about 15 members. It's comprised of healthcare providers, the health department, there's community stakeholders. We look and analyze this data and come up with prioritization rankings. And when you're looking at how you prioritize ranking, it's based on what's the greatest identified need, what's the feasibility of being able to address the need, and do we have the adequate resources to be able to do something? Because it's kind of futile to choose that you want to focus on something when you have no resources to be able to achieve that. So that's where we work through the prioritization. Once the prioritization occurs, then we put together action plans, and then we evaluate that and monitor the progress. And the Healthy Carolinians of the Outer Banks, which is chaired by the health representative from the health department, helps kind of keep all of that on track as we move through the process. Next slide, please. So we often like to start out with just acknowledging, and this information comes from the focus groups and the surveys, is that generally Dare County, as hopefully you all agree with me, is a wonderful place to live. We have lots of assets. We certainly have needs, without a doubt, but it is a phenomenal place to live, work, play, raise a family. There's lots of strengths. 56% agree that Dare County is a great place to grow old. 20% disagreed, and I have a slide later to kind of get to what some of the rationale was behind that. 87% said Dare County is a safe place to live. Just over 60% said Dare County has plenty of help for those during times of need. One thing that was noted pretty high this year was the economic impact. Only 35% said that there's plenty of economic opportunity in Dare. And we've seen that with just a number of things, but this really impacts health. for those of us who work in healthcare, we know the social determinants of need, those things like stable housing and employment and your income, can really affect your ability to have the quality healthcare that you need. So these are important things for us to look at and evaluate. Next slide, please. So I mentioned we capture demographic information. The estimated population for Dare County is just over 37,000. We'll highlight from this slide, Dare County is a well-educated community. We compare the education level at Dare County. 94.2% of individuals in Dare County have a high school degree or higher. That's higher than both the state and Eastern region average, which is right around 86 and 87%. 34% have a bachelor's degree or higher. That's also higher than both the state and regional average. And our high school dropout rate is lower than both the state and Eastern region. And as a mom with 2 children in the school system, I feel blessed that Dare County has such a strong school system. And I think that also contributes to health when we're looking at recruiting healthcare providers and staff to work in the field, is knowing we have such a strong school system. Dare County is, I think it's on a different slide. Dare County has a higher veteran population than the state, a little bit lower than the Eastern region. You can see our gender split is 50-50, and then our population statistics are there on the right side. Interesting note at the bottom, 7.5% of residents are Hispanic or of Latino ethnicity. That's an important note for healthcare as well, because for us, certainly at the health department, we have a large percent of our population that is Spanish speaking. So we have to make sure that we have interpreter services as well as our information and English as well as Spanish. So you have to be mindful of your population so you're able to do the appropriate outreach, communication, and assistance. So the next slide identifies the top 5 items that we put on our watch list. This was based on both the primary and secondary data. And as Amy mentioned, over the past 20 years, these items really haven't changed much. They've shifted a little bit, maybe in what's number 1 versus what's number 5. But mental health, access to care, substance abuse, older adults, and cancer have remained our top 5 issues. And Dare County is not really unique. If you look across the, not only the Eastern region, but throughout the state and in the country, these are big items. Again, they may shift in what's 1 and what's 5, but these are often items that are significant in a lot of communities. Out of this watch list, the priorities that were selected for this particular community health needs assessments over this 3-year period were mental health and substance abuse. And as Amy mentioned, we had the Access to Healthcare Task Force intact, but the last meeting was a month before the pandemic hit, and it's just all of us were just taxed for time of where our time was being allocated. The next slide, and just so you know, this PowerPoint for the committee, if I can't remember, oh, you all do have it. That's right, you have a copy, but if you all want a copy of this, we will put this on our website as well. This presentation, so you don't have to read the whole 280-page document. Right now, the 280-page document is on the website, but we'll also add this PowerPoint, because I know from your seats it's hard to see. This chart is showing you the rates of causes of death in Dare County over different 4-year increments. And I think the big thing to just point out on this slide, cancer is number 1 across that as far as the rate for causes of death. But there hasn't been a significant difference over this time span either. And this time span, for those of you, it might be hard to see, is from 2012 all the way up to the most recent data, 2019, but it's in 4-year increments. There's been some drop. Overall, the decrease in pneumonia and influenza deaths, that's probably the most thing that you could say is statistically significant. But it's just been some fluctuation here and there. And the other thing that's a little bit hard with this too, when you're looking at the big gap in time, is the 4 years also cover each other. So, the first period of time is 12 to 16, then it's 13 to 17, so it still covers some of the previous time. It's really hard in a 3-year period of time or a 4-year period of time to move the needle tremendously on a health outcome measure. But I think the overall, the these are the items that we continue to watch, that we continue to build our support services around in our community. So we'll take a deeper dive into a few of these, with the next slide being mental health. One of the things undoubtedly with the pandemic, and there's a COVID slide later, that was identified in focus groups is the impact on mental health with COVID, significantly with depression and anxiety, spanning across all ages. Overall, since the last community health needs assessment, there was a 3.14% rate decrease in death by suicide. Though Dare County remains, for Dare County adults, suicide is still the 8th leading cause of death, and that's higher than North Carolina. So the rate for Dare County is 19.3. The rate for North Carolina is 13.4. That is something that the Breaking Through Task Force, they actually have an initiative going on this month. They have a documentary on suicide. They've been able to connect with families who have been impacted by this and put a really powerful documentary together. So this is something that's specifically being targeted now to be addressed by that task force. The emergency or EMS, emergency medical service visits for mental health in 2020, they increased to 4.9% over 2019, which was 3.6%. We've had an increase in the calls to mobile crisis. This is a 24-hour service to help those in need. There was a 41.17% increase between 19 and 20 in children's mental health calls, so families or individuals calling for support, and a 216% increase in calls for individuals 19 to 25. So certainly, those are alarming statistics, and it just points to the need of what a critical service the mobile crisis service is. Again, it's a 24-hour service. Yes. You did. It's not good. 41% increase in children's mental health calls to the mobile crisis line, and a 216% increase in calls for individuals ages 25 to 40, or excuse me, 19 to 25. Yep. A 47.1% increase in emergency department visits for behavioral and mental health needs for children during this period. 307 is the average visits per year for behavioral health concerns, and that was between the time frame of 2017 to 2021. Moving on to substance abuse. And I will say, we have one thing that's really tough in public health, speaking for public health. Well, first off, we have an amazing Saving Lives Task Force. It's chaired by Commissioner Wally Overman and Roxana Ballinger, and just a really dedicated group of substance abuse professionals that serve on that committee. One of the things that's really tough in public health is how you measure what would be happening if you weren't doing the work you were doing. And so, when we see these statistics, and they're not pleasant, they're not pretty, and it still speaks to why so much work is still needed. But it scares me to think what would be happening if we didn't have these amazing dedicated professionals doing what they're doing, because we have increased resources for individuals in Dare County over the last 5 to 7 years for mental health needs. But when you still see numbers like this, it's alarming. But it doesn't say that what we're doing is not working. This is just a monumental issue that we have been battling as a country for years and years and years, and of epidemic proportion and generational. And so you're fighting a constant uphill battle, but you don't give up because you are making a difference. So moving on to substance abuse. The rate of unintentional medication and drug overdoses is higher. That's 24.5% than the state average of 16.7%. It's also higher than the state average is the rate of unintentional opioid deaths, 21.7 as compared to 13.6. The EMS visits for substance abuse also increased, as did the mental health I showed on the previous slide. Not as significant as mental health, but in 2019, 4.3, 2020, 4.4. But sometimes it might be classified as a mental health, and also it's often very much co-occurring. So maybe the first classification is mental health, the second classification is substance abuse. So it gets classified in one, but very often they're hand in hand. So 42% of those who responded to the community survey identified substance abuse, misuse, and as a health behavior residents needed more information about. So that's something that's certainly on the task force agenda as well, of continuing to get information out. Oftentimes, individuals, you can't think you just say something once and it clicks, whether it's where to get help or what the problem is or where the resources are. It's they need the message when they need it. And that might not be when the next person or the other person needs it. So that's just a big challenge in this communication realm, which is why there's still so much work to be done. The next slide is looking at access to healthcare services. So this certainly is something for this task force, some really relevant data here. I'll draw your attention to the bottom chart, and I'll go through that because I know you all probably can't see that in the audience. So this looks at some of the different genres of healthcare and looks at our provider to resident ratio. And so for mental health, there has been improvement between 2018 and 2021, but we're still significantly less providers per resident than the state average. So while we improved from 640 to 610, meaning there's one provider for every 640 residents. At the time of the assessment, there's one to every 610, so that's an improvement. But the state is 1 to 390, so we're off significantly from that. Primary care, we also saw improvement, 1 to 1,700, now improved to 1 to 1,600. The state is 1 to 1,400. Again, one provider for 1,400 residents. Non-physician primary care, so your mid-level practitioners, we are 1 to 1,280, whereas in North Carolina it's 1 to 750. Dentist, it's the one area by paper that we are higher. And I say by paper because this is based on where your physician is registered with their certifying board or agency. So if a dentist still maintains his license and lives in Dare County and is registered, that counts in this figure, even if he or she are not practicing currently. So we're 1 at 1,480 as compared to 1 for 1,720 in the state. But these figures make sense. I mean, we want to improve on them, but they make sense because we're in a rural area. We're being compared by the state, which factors in Raleigh and Mecklenburg and Greenville, and where you have medical centers and, big health systems in those communities as well. So also of note on this side is 15% of the population, 0 to 64, are uninsured. So certainly when you're looking at what the work of public health and the community health, in our free and charitable clinic, and certainly charity care that happens with the hospital, that's an important metric. And the rate of individuals with health insurance has decreased since the last assessment by 2.18%. The next slide is a picture of our older adult population, and this is important. We've known for many years that Dare County has an aging population, and the first two percentages up there really speak to that. 31.3% of our population is between the ages of 45 and 64. That's higher than both the state and the regional average. The state is 26%, and the regional average is 25%. And our population 65 and over is 20.7%. Again, much higher than the region and the state. The state at 15%, or 15.8, and the region at 15.7. The one shining star, I would say, is our percent of those individuals 65 and over living in poverty. Fortunately, we are much lower than the state at 2.9%, whereas the state is 9.1% and the region is 10.3%. The leading causes of death, vary again slightly in order based on the specific subset, whether it's 65 to 84 or 85 and over. But they're within the same 10 that we showed on the original slide there. So moving on to the next slide is just an overview of our cancer data. There are 3 cancers where we're lower than the state average. That's breast cancer, prostate cancer, and colorectal cancer. Other than that, our other averages are a little bit higher than the state average, with the exception, when I say a little bit, of the oral cavity and pharynx cancer. That's pretty significant at 16.3% compared to North Carolina at 6.7%. So I don't know if we have any dentists in the room, but that's something that needs a little bit more delving into to understand that variance. Why is that so significant? All cancer incident in Dare County has decreased by 4.73%. Certainly, we have a lot more resources for individuals with cancer in recent years than we had, say, 7 to 10 years ago, with the work at the hospital and with patient or cancer navigators, and really trying to help connect people to the services that they need. The next slide is a highlight of just the COVID-19 pandemic, which personally I'll have to say, don't really even want to talk about, but but just a couple of things there I'll point out from the data from the community survey that I thought was nice. 84% of individuals said it was easy to avoid getting sick. So despite all this going on, I think that is partly connected to the next one, where 89.9% of people said it was easy to get information on how to protect yourself. So getting that information out about what you should do, how you should do it, what measures you can take. Certainly, I think it also correlates to the high vaccination rate in Dare County. Dare County was second in the state for the highest percent of individuals vaccinated, with 70% of the population being fully vaccinated. This was back when the data was collected, and 74% of the population having at least their initial dose. The next slide is a snapshot of some of the data related to the economy. Yes, sir. Thank you. Thank you. Thank you. Thank you. Thank you. For the economy, the median household income, just over $59,000. 9% of those living in Dare County, are living in poverty. 15% of which are children. And I already indicated on an earlier slide, 2.9% are individuals ages 65 and over. 7% of households in Dare County had SNAP benefits. That's basically food and nutrition supplemental benefit in the last year. The top 5 employers by size in Dare County Schools, Dare County, Vidant Medical Center, Food Lion, and NC Department of Transportation. And we see that some of our greatest population bases of poverty are in some of, Manteo and Wanchese, Buxton, and then Hatteras Village at the largest percent. So some of our most rural areas of the county. And that really concludes the summary. Again, there's way more information in the 280-page document. We will post this within the next 24 hours if you're looking for this snapshot. It's darenc.com, and then you click on the Health and Human Services and Publications. Dorothy, is that probably the best way to direct? A link on the... Wonderful. Okay, so Dorothy's going to work some magic and put a link on the Dare County homepage to make it really easy to find. Thank you.
Sheila, thank you for that. Does anybody on the task force have any questions or want to speak to the presentation that was made? Okay. Okay.
Thank you for excellent coverage of a lot of data. In a recent conversation, I was asked about the age of some of the data in reporting that is used, and does that impact today? And I thought it might be useful if you could just explain some of the limitations of data collection, particularly when it's not directly in your hands. That might clarify it for some people and reinforce what you have presented.
Absolutely. So as far as the data, depending on the source, whether it's the CDC or the Center for Vital Statistics, some of that data, we are incredibly limited because it may be the most recent data we have to pull from is 2016 or 2018 or 2020. It varies by source. Certainly the primary data is, that was collected within months to weeks before the compilation of the assessment. But the secondary data, you're greatly limited by what's released to the public. And so some of that information is certainly outdated. But each year you are comparing what you have. The previous assessment has that same limitation. So it's factored in, but it's the same limitation every 3 years consistently. So it's a consistent limitation.
I have a question too. You had mentioned during the residents to provider ratio with the dentist that, if they're retired but they're here with an active license as a part of that ratio. Is that also the same thing with the PAs, the mid-levels and the MDs?
Yes, all providers.
Anybody? I have a question.
Yes, sir.
Okay. On the access to healthcare services, and I think that's what stimulated the conversation where we are today. On that slide, is that based on the permanent population of our county?
It is.
Okay.
The 37,000.
Okay. So that's based on 37,000. So those ratios really don't take into account the seasonality of our population, of our Dare County population, and the northern Crotuck Outer Banks population. Is that correct?
Correct.
Okay.
Mm-hmm.
So that would that change those numbers?
Well, certainly
Those ratios?
at different times of the year. Certainly we know that we're serving a lot more people. Amy can speak to that with the urgent care visits and how many patients they go to, from seeing on average in, say, January to July. Same thing with our EMS visits. We've had the busiest EMS summers this year for Dare County Emergency Medical Services. Historic numbers. So without a doubt, I think that is factored in. Now, what it does not count, though, with this number, again, Amy, I don't want to speak for you, but when we're bringing in staff where their license may be based, so if you're your travelers or your other physicians that you bring in seasonally to help, they're not going to be counted in our numbers. So it kind of goes both ways.
Which we do for both emergency department and urgent care. Our emergency department volumes double in the summer. Typically in February, we may see 40 to 50 patients a day. And in the emergency department in the summer, we typically see 90 to 100 patients per day. So that volume does double, but we do add travelers or locums physicians to handle that volume.
Okay, along that same line, this is based on the county as a whole, which is whatever distance it is from one end of the county to the other. Or the pockets of the county that have less providers, or has that been evaluated?
That has not. This looks at it as a whole. So it has not broken down. It's not broken down by municipality or unincorporated Dare.
Okay. Thank you. Anybody else? Okey-dokey. Moving on. I think the next item on the agenda is the introduction to the community health care for Manteo and Roanoke Island. Before we start this is kind of the excitement I have in introducing this crowd from my friends, my newfound friends from Englehart. There's a couple of stories that in my past, in my faith, that I'd like to share. One, all those that are parents or had nieces or nephews, grandchildren, remember the story of the little engine that could. Uh, you do? Well, that is what's happening today with the next presenter. Also, if you remember in the Bible, the story of the Good Samaritan. This group that's coming forward today wouldn't be here if it wasn't for the quick thinking of Melissa Dickerson. Joe Rockenstein made an inquiry after reading or hearing on the grapevine about the conversation we're having in Manteo about healthcare. He called Melissa, and immediately Melissa acted. And Melissa, thank you for doing that. So Joe, you exemplify Northeastern North Carolina, and that's what most of us have come from, small communities that are always willing to help each other. And so Joe, in saying that, please come forward and do your presentation. Thank you for being here.
Hello. So what do I click for this? This little thing right here? Okay.
And Joe, before you start, we have two people that just joined us. Trey Lewis, could you raise your hand? There you go, Trey. He's with Senator Burr's office. And Betty Jo, could you raise your hand, representing Senator Burr? They have joined our group also. Excuse me. I got it confused. Thank you, Betty Jo. I'll get that foot out of my mouth. All right, Joe.
All right. Well, welcome everybody. I just want to start out by saying that first of all, this is really as a result of the article that was put in the Times. And it was forwarded to me actually by one of the nurses that works for us in Englehart. She's from Manteo. And she actually sent me a text with it and said, hey, maybe read this, check it out. And, so it's kind of funny or ironic how all of these things start, but someone that lives here in the local area saw the article, got the article to me, and then we went from there. So it's interesting, the chain of events that kind of lead to these things that happen. So today, my main goal is, first of all, is just to give you an introduction to community health centers and what an FQHC is. Try to give you an introduction to myself and to some of the board members that have come as well, and some of the good people that work for the centers, both in Englehart and Okokok. So first of all, just on the agenda, I just wanted to just go over what we're going to cover. It's an introduction, of course, our board members that have attended, myself, a little bit of the history of the organization that we are, what is a federally qualified health center, because it's probably one of the best kept federal secrets that exists, how we can deliver services to the community, and the plan for Manteo, Roanoke Island, and then we're going to leave it open for questions for anybody that has questions for us. So first of all, I just want to take a minute to thank and just say that we have, I believe, the best board members in the world that are a part of our organization. They are people who are patients. As part of the requirement for being an FQHC, 51% of your board needs to be comprised of patients of the health centers, which is really important, obviously, to have patient input into how the organization moves forward and the different things that are presented to the board and voted on. So first of all, I just wanted to introduce, we have Art and Alice Keeney and Earl Pugh, who've all come up, and they are current board members. They have been with the organization forever. So they're very an integral part of what we do whenever we look at the things that we're looking to impact or put in place inside of the community. So then you have myself, right, Joe Rockenstein. I am a guy from Pittsburgh, Pennsylvania. So people look at my last name, they're like, you're probably not from around here. And you're right. My wife and I moved down here last year. I started at this position last June. I came from another larger federally qualified health center, and I've been working in nonprofit healthcare for about a decade and a half in various institutions. Well, only two actually, but that has been my career path as I've ventured through looking at healthcare. And I really just wanted to say this on a personal level, that what FQHCs do is they bridge the gap in healthcare for people. One of the main goals that we have as an organization, and it's the mission really of all FQHCs, is to try to serve the underserved, which is really one of the biggest gaps that we have today. And I'll kind of go into that a little bit later. So that's me. Again, my name is Joe Rockenstein. Just wanted to go through our history a little bit. Both centers were started individually. So both Ocracoke and Englehart Medical Centers were their own individual units. Neither one of them were an FQHC. They were both rural health clinics that were assisted by the Department of Health and Human Services side of the state of North Carolina. So the Office of Rural Health, that is actually who gave them their funding and gave them an opportunity to provide services to people that live in these areas, which is really critical, obviously. So what happened is that in the late 2008 to 2010 area, some of the members started to realize how important it was that they were continually being able to serve the people in the community, but there was financial difficulty for the organization at that time. And so what they realized is that they could be stronger together. So what they did is that they banded together, parties from both sides got together, and they formed what is today the FQHCs that exist, which is Ocracoke and Englehart Medical Centers together. So in 2014, they became one organization and became a federally qualified health center. Let me just tell you, there's a lot to do in order for that to happen. You don't get federal grant and federal funding by accident. You have to do a tremendous amount of work and application process in order to be accepted into that. So some of the road through COVID and Dorian. So some of the things that folks don't really realize, I think, is just how big of an impact that Dorian had on Ocracoke. For those of you who were here or were around or went down to go see some of the devastation that occurred, one of the things that was consistent about the island of Ocracoke was the health center remaining open and providing services to people. So along with the Army Corps of Engineers and the people that live on the island and work at the health center in Ocracoke, we were able to maintain health services throughout that entire campaign. As you can imagine, when everything is destroyed and people's lives are thrown askew, this was really critical and important for the people that live on the island. So one of the other things, of course, not long after the devastation of Dorian happened, we had COVID that came along, as spoke about before. I know we're all a little reluctant to talk about COVID because it was, and it still is, a painful topic. But the reality of it is that our health centers, along with, in conjunction with the Hyde County Health Department and some others, were able to put together tremendous testing and be able to provide vaccinations for people that live in those areas, of course, at no cost, and to be able to bring people in so they could get those vaccinations done. Because one of the challenges that we faced in the areas that we're at is transportation, especially in Englehart. As you can imagine, there's folks that can't get to the medical center. So those challenges in each one of those locations, as far as Dorian and COVID, really made the organization stronger. So one of the things that HRSA did was to recognize that there was a great need for them to step up to the plate and deliver the capability of these health centers to deliver the services to the people that lived in those areas. And that's exactly what they did. So through the function of many different processes, we were able to provide a lot of services for folks that lived in that area as a result through all of these hard times. And from that, we've actually grown. We've actually been able to increase our size by about 1/3 since I've came on board as far as the number of employees that we have. We've increased our patient fold about 30% since I've come on board. And that has to do with a lot of different reasons, which I'll kind of speak about a little bit. But one of the things that we're able to do is that we work in conjunction with other community partners to be able to provide services. As you can imagine, that's one of the things that this health assessment kind of talks about, is the lack of services that are in the area. Mental health specifically being one, dental care, another one that we're looking to address, as well as physical health. So these are all three areas that were mandated by HRSA, our federally governing body, to provide services for. So one of the things that we're able to do is to work with what's called an integrated care model. So what that does is it allows us on a warm handoff basis to work with people that are patients of the health center and get them into mental health and get them into dental. These things all work together. There's a symbiotic relationship between all of these things that we are looking to address. And how you do that best is by having a care model that allows you to service patients in a whole patient setting, which is really the key difference between FQHCs and perhaps other doctors' offices as an example. So what we're looking to do is we're looking to service the whole person, not just their physical health, not just their mental health, and not just their dental, but the whole person. And that's what we look to do. So our present day, we've been able to achieve a lot of success as a result of that. Like I said, we've been able to grow the organization and expand the services that we're able to give. I have mental health services in Ocracoke. I have mental health services that will be starting in Englehart very soon on site in person. Now, let me just tell you, there are some challenges in getting behind mental health professionals to come to Englehart, North Carolina. So we are going to do whatever that it takes to make sure that we have all of these services for the communities that we serve. That is our mandate, and that is our promise to the people that live in these communities. So what I do is I'm a facilitator. I'm just going after all of those things. I'm trying to bridge the gap and make those things happen. So that's really what my job is. My job is to hook the services up with the community. It's all of the people that work for the organization that really do all the work. I'm the one just putting it out there so that way people have an opportunity to be able to come to us and to go and have these services done. So let me just go on to the next one. It says, what is a federally qualified health center? So I'm sure that probably to some folks here is that they're wondering, what is a federally qualified health center? There are thousands of federally qualified health centers in the United States. Most people don't know that. They don't even know what it is. And it might not be something that people really know or understand because they're doctor's offices, much like doctor's offices you'll find anywhere. However, there's a special designation for them, and there is a reason why they are a federally qualified health center. So first of all, you have to apply through grants to get the federal funding in order to be a federally qualified health center. FQHCs, which are governed by Health Resources and Services Administration, HRSA, that's our federally governing body, and they set aside all sorts of rules and regulations that we need to be able to follow. And they have goals and expectations for us that are above and beyond what you'll find at like CMS as an example. So these are all things that we're held to a little bit higher of a standard when it comes to quality of care. And again, these organizations are meant for quality, not quantity. So we're not trying to push people through in fast fashion. There's no robotics about this. This is a very direct conversation that we're having with the people that come to us as patients. We need to learn them, they need to learn us, and together we come up with solutions to problems, not just the physical problems, but all of the other issues that kind of come along with it. So as a part of this, our mission is from HRSA is to serve the underserved, which I talked about. So the underserved are the people that are in the community who don't necessarily have access to healthcare. That might be the people who are uninsured, the people who are unemployed, the people that are underinsured, and in some cases, even people that are on Medicaid and Medicare. These are all critical for people to be able to have services that they can go to and not feel like that there's a financial barrier for them to be able to see the doctor. That's very important. So this is creating whole person care without any financial barriers to care. That is one of the biggest mandates from HRSA, is that there are no barriers. So regardless of whether you have insurance or don't have insurance, which is something you see on the health assessment survey, there were actually people that said my insurance wasn't accepted. That's never an issue. There are people that feel like that they can't afford to pay for services. That's never an issue. There are no barriers to care, period, whatsoever. So we're bridging the gap in healthcare for Medicaid, Medicare, uninsured, and underinsured, and provide accessibility to healthcare for all, regardless of their walk of life or anything, whether they're financial or insurance or otherwise. On to the delivery of services. So there's, as I said, there's no prerequisite to being a patient at an FQHC. It's not a free clinic, and it's not a regular doctor's office. There's a definite distinction, right? We still bill out for patients. We still charge people for seeing them. However, we do things a little bit differently. So one of the things that we do is that we deal with what's called sliding fee scale, or federal poverty level. So one of the things that we take into consideration is the person's ability to pay. And based upon that, we build a whole guidance around that, so that if you don't have the ability to pay, you're not charged, or you're charged only commensurate to based upon what your salary is. So we do that through time-proven systems that we're able to look at, that people provide us some information, and we're able to get them into this what's called MVP program. So that is the sliding fee scale. So that means is that people that do have problems affording their medication, people that do have problems paying for doctor's visits, people that do have problem for maybe even seeing mental health professionals, are able to do so without being concerned about what's going to come out of their pocket. And again, this also works with insured folks. So one of the things that we've run into over the past several years has been the increasing amount of money that we have to put out of our own pockets, even though we do have health insurance. At first it was $500, then it was $1,000, then it was $2,000, now it's $5,000. So the out-of-pocket expenses that individuals are having to incur just from going to see, and especially mental health professionals, is a real problem, because you have to pay that every time you go see the provider. Now, these are all things that we're able to overcome through the use of these programs, so that people were able to come and see us. So we have community partnerships that we have with the county health department. I talked about Hyde County Health. And one of the things that we do is, we did recently also with ECU, was to open up a dental clinic over in Swan Quarter. Now it's only open one day a month, okay? And this is really the result of the hard work of the health department there and ECU. We were just a partner in this. But these are the kind of things that we're looking to do. We want to be involved with what the county is doing. We want to be involved with community assessments. We want to be involved with community partnerships, that we can actually deliver better services to the community as a whole. So again, our focus is on quality, not on quantity. So that said, the plan. So here's what it is that I've come up with, that I envisioned for where we're at currently, based upon the number of people that are in the area and the services, or sometimes the lack thereof, is that we're looking for 2 to 3 providers that would exist in this health center. There would be 5 to 6 clinical professionals. So again, that would include nurses, MAs, front desk, lab technicians, persons of that nature. 3 administrative personnel, and pharmacist and pharmacy technician. So one of the things that I wanted to kind of address was, there have been a couple of questions. So first of all, as we are federally funded, we do not interfere with anybody else's funding streams. We are not a part of and or take away from any other individuals that receive money in any other fashion. This is completely separate and segregate that was set aside by HHS. That is the federal governing body that mandates or gives out these grant dollars. So, but secondly, people want to know how exactly we can do this. Because one of the things that we're looking at here is that I also want to have 1 to 2 mental health employees. And also, at future considerations, we want to have a dentistry program. So how do you do that and maintain an organization? Because that's always been one of the challenges for healthcare. Something that has really come and reared its head over the past several years has been the fact that there's a lot of expense that goes into this, but some of the reimbursement isn't all that great. So how do you make ends meet? FQHCs, in my opinion, are the best healthcare model that exists for primary care. The reason why I say that is that you're able to focus on quality of services. You're able to focus on all the quality initiatives that you're trying to deal with all the various insurance companies. You're able to fully staff your organization, and you're able to do so because of 330 grant funding from the federal government. You're able to do so because you have enhanced reimbursement for Medicaid and Medicare because you are an FQHC. And you're also able to do so because you roll with the 340B program, which is the pharmacy program from OPA at the federal government as well. All of these things combined help to make our organization whole in a result that we are able to fully staff and fully service the community without having a problem with being able to financially stay afloat. Because truly, that's been one of the greatest barriers to provide healthcare, is being able to make sure that you have the capability of delivering services to the community and still being financially viable, nonprofit or otherwise. You still have to be able to make ends meet. And this is how you do it. It's been wildly successful over many decades. This is not something that's newfangled by any means. So I just wanted to kind of put that out there, how we're able to make the success of the organization financially. So,
Joe, Commissioner Ross has a.
In the last 60 seconds, you just answered the question of the ages. You kind of said we put 3 and 340, and we got grants, we got money, and that's how we do it. I'd like you to go just a little slower, because I don't know if anybody besides me does not know what 330, 340.
okay.
Okay.
I can take this off. Okay.
We've been wrestling with this for decades.
Well, that's exactly right.
Just got it there.
And you don't mind if I just address him directly. So one of the things is that I think that everybody has realized is that the cost of healthcare has increased, and it's not just for individuals like us. It's increased for all of the organizations. So whether you're a small individual family doc or you're a giant healthcare system, it really doesn't matter. These are difficult times. And it's, you might have noticed is that that healthcare professionals have to see a tremendous amount of patients in order to be able to make a buck. I mean, that's the reality of it today. So, I mean, we've talked to doctors that we've interviewed as far as coming in to our organization. And it's not uncommon for these doctors to see 35 plus patients a day. Now, I want to tell you, that's not a whole lot of time that you're getting to spend with that patient. So that makes the experience maybe not so good for the patient. So, but the reality of it is that's what they've had to do. I mean, I don't look at and blame anybody for doing what they're doing. They're doing exactly what it is that they need to do in order to survive. So it's just that in this particular model, what it is, first of all, the 330 funding, that is a federal grant. So the federal grant comes up every 3 years, and it's a competitive grant. Matter of fact, I just got done applying for it about a month ago. So the federal grant is 330 grant, and it's based upon the size and the service area that you have. And I don't want to get too into the weeds there, but it's federal dollars that comes in. So that's part of it. That's part of your money. Okay. It's going to be $956,000 per year. Yes. Okay. So that's part of it, right? Keep in mind is that any one particular thing doesn't make this work. It is a combination of things. So you have the 330 grant. Then the next thing you have to look at is the enhanced reimbursement. Okay. So what does that mean? We want to see Medicaid and Medicare patients. We want them. We want all of you. Anyone who's on Medicaid and Medicare, we want you to come to our facility. The reason being is that we are provided an enhanced reimbursement through the federal government to be able to see and service those patients. Now, one of the challenges that's been in every doctor's office is that, you know, they're getting these really tiny reimbursements for seeing these folks. How do you make ends meet? You don't. You lose money on that visit for the most part. And so, but with that guaranteed enhanced reimbursement that we get for the patients that we see under Medicaid and Medicare, well, now that also depends upon where you're at. So Medicaid is based on state to state. So now the state of North Carolina does not participate in expanded Medicaid services. It is what it is. But we're able to get about $325 per person on Medicaid when we're servicing them, which is critical because that allows us to spend the time that we need with that Medicaid patient. The same thing with Medicare. Not quite as much, but we're able to get enhanced reimbursement to the point that at least it pays for their visit. It pays the provider to be able to see them, the staff, and the time that you're going to spend with them. I mean, for your Medicare annual visit, you should be spending about 45 minutes at your doctor's office. When's the last time any of you spent 45 minutes at your doctor's office? So, I mean, so right, this is a big deal, but that's a part of why this model works. Okay, all right. I don't want to. Okay, so we have the enhanced reimbursement through the PPS rate. And then the last part of this, the last functioning part of this is the 340B program. And okay, so let's talk about that for just a minute. So through the Office of Pharmacy Affairs, what it is that the federal government has a deal with the pharmaceutical companies. The pharmaceutical companies will allow a enhanced reimbursement for FQHCs to be able to deliver medications to people that otherwise wouldn't be able to afford them. Okay. So you may or may not be aware, but hepatitis C is an example, HIV. Those are big dollar medications, and most people can't afford them on their own. These programs allow individuals to come to our facilities and allow them to be serviced and get the medications they want at prices that they can afford, if you can believe that, because these are tens of thousands of dollars. So we get enhanced reimbursement for the medications, okay? That's how the 340B program works. HRSA. Yes. HRSA is the federal governing body. So, yes, they are. They are. Yes, and to some, that's exactly right. Now, here's the beautiful part about the relationship that you have with HRSA as we go. We still have autonomy. We're still an individual organization. We're not owned by the federal government by any means. Now, they ask that you provide justification for the things that you do. You need to be able to give them reporting. You need to be able to show them the body of work that you're doing. Your quality numbers have to be well, and you have to be able to deliver on the services that you say you're going to in the communities that you're at. So they keep and make sure that these FQHCs are delivering the services that they say that they're going to deliver. So that's what HRSA is, and that's what HRSA does. And with that, okay, so I guess I'll just open it up for questions at this point. I've given a lot of stuff. I'm sorry if I went too fast. I'm a little nervous. So apologize. Yes, sir.
I have a couple questions, actually. I own a pharmacy and I deal with HRSA with the COVID shots. So the uninsured will come in and HRSA pay for the COVID shots.
Correct.
That money dried up probably, I don't know, 6 months ago. However, I'm still required to give the shots for free and not get reimbursed in any way, shape, form, or fashion. Doesn't bother me. I'm okay with that because I'm helping the community. However, if most of your grant money's coming from HRSA, what happens if that happens to you too?
Is there a risk that someday that HRSA could just dry up and wither away? Sure. And that's why you have to make sure that you're building an organization that's going to function as a company. So one of the philosophies behind an economic philosophy behind building a business is called going concern. You're always looking at building the business so that way that you can survive different scenarios. So again, this organization has been able to build a nice little nest egg throughout the years. And a part of that is because we're able to get those reimbursements. So what you have to do is make sure that you are diversified enough that you can survive a downturn, an economic federal downturn. Because really, truly, and honestly, even though HRSA and these federal dollars have been around for decades, there is always that possibility that someone could come along and say, we're pulling this plug. So the best thing that you can do is be financially prepared and be business diverse so that way you can handle those situations.
Well, with that being said, with the elected officials in this room, it shouldn't have to be this way. The problem that we're facing right now, you've addressed, and I've stated this since day one with this committee. This is a nationwide thing. It's not a mania.
It is.
And you've already hit the nail on the head by saying, hey, it's the reimbursements. The payers are less and less, our paperwork's more, and there's less reimbursement, more audits, et cetera.
Yes.
So if the elected officials in this room can try to help us out as a country, we wouldn't have to deal with this. I bring this up in my profession. I email, my guys in the pharmacy realm, and the pharmacies, we've been beat up since the 80s.
Oh, yeah.
But now, it's hitting the other side of the street, and the other side of the street needs help.
Yeah.
Plain and simple. And it's not, when people hear from me, it's a business owner that's whining about being paid. It's not that. It's about surviving. And it's hurting the communities throughout America.
It is. Yeah, you're absolutely right.
Anybody else?
Just to add on to what he was saying, if the politicians and the people who serve us as a people don't understand that we can't afford to pay thousands of dollars for insulin or any of the other medications. I know my brother, his one medication was $1,200, and he can't afford that.
No one can.
So if we don't have expansions or we don't have some type of fund that looks at people who cannot afford that, we're going to be just exactly where we are now, or worse.
That's right.
So what are we going to do? I mean, we have politicians in here right now who serves us. How are you going to make it better for not just Dare County, but for the state of North Carolina, as well as all the other states? That's what we got to look to, because as we age out, I'm 69. That's not as old as some, but I'm feeling pretty darn good. But I know I'm going to get to a point where I'm going to need expansive care. So thank you for bringing your presentation, but unless it goes further than what we have now, we still haven't achieved a lot.
I would agree. There needs to be, and if I'm allowed to, one of the things that we have to do is look at this on a community by community. And the one thing that isn't really, and I can't unfortunately control, nor can anybody in this room, what happens even in other parts of the state. So the best thing that we can do is try to build. And I think that the one thing that the FQHCs do, our model, I think that's the model of the future, to be honest with you. I think that healthcare has to be delivered in such a way that it allows for affordability and that it allows for some of that old time sort of doctoring that goes on that I think that people have been missing. A lot of this works together. So yeah, the community that we're in right now can be better, and there can be more services here. And I think it's up to us to make that choice and to move forward with that. And while we might not be able to effectualize change on a national level, we can certainly make a difference in this community.
Anybody else? Joe? I mean, Randy?
Joe Rand?
I'll respond to almost anything. Name tag's not large enough for him to read. Let me dive down in the weeds a little bit, if you please. You just mentioned the 340B pharmacy program that you're able to operate under. I have a little bit of familiarity with that, and I know it's a discounted rate. Could you comment on the relationship between a clinic like yours and 340B and local pharmacy?
Yeah,
And
absolutely.
how that works or doesn't?
Yes.
Because I think it's an important consideration.
It is. And, one of the questions, and Kevin, I mean, this is like directly for you. So one of the questions that I was asked initially is that, well, if you put a pharmacy in there, how is that going to impact the local pharmacist? Well, first of all, these pharmacies, and the pharmacy that I would look to put it would be a closed pharmacy. That means it would only be available for the patients of the medical center. That's number one. Number two, it does give discounted rates, and it allows people, especially that are on the spectrum of not being able to afford their medications, $1,200 a month, affordability in paying for their medications. I mean, essentially, there are some folks that might pay $1,200 per month for medications, and if they're on MVP, what is it, Shaq? What's a scale on there? I think it's $20 or $30 for some folks. So that is at the most. So this is huge. I mean, I kid you not, it's huge. And there are going to be people, I think, that are, financially hurting, that are probably going to come to us, and it might have an impact on someone like Kevin's business to some small degree. However, it doesn't change much in regards to the average Jane and Joe in them being able to get prescription medications. If they're not coming to the health center, they're not going to be eligible to participate in our pharmacy.
The only issue I have with it, truthfully, is that I think everyone should be able to have that opportunity, and it's not you. I applaud you for being here. I applaud you for what you do. I don't mind losing some people that if I know that they can get that $12,000 prescription, I can sleep better knowing I lost that. Because out of that $12,000, sometimes I make a negative $200. I get reimbursed a little bit what I paid for it.
Yep.
So I'm okay with them going through 340B, but to me, it's not fair, and this is not yours, but it needs to be, everyone should be able to.
So let me try to clarify a little bit further. The reason why that this closed pharmacy, and the reason why you do that is because under the 340B regulations, you can't provide those services to people that are not patients of your medical center. And the reason why you kind of do it as well too is you really don't want people shotgunning your pharmacy to come in to see somebody once every 3 or 4 years so they can get their prescription at a lower rate. You want them to come in for actual healthcare. So yes, I do wish it was for everyone, but keep in mind is that this really impacts the people that are uninsured, underinsured, low income, people in poverty. I think it was 15% was the rate that we saw in the assessment. So that still is a large number of people that can be impacted by this. So it's a good thing for those. Randy, did I answer your question all the way?
Mhm.
Okay.
Well, I would have to ask Walgreens, CVS, and Kevin if you did, but
It's very complex, and
It is.
even though I've been through many, many things on that type of stuff, it's over my head, not hours I've spent.
It's really difficult. And one of the things that if you are in the government, you might have noticed that there's been a big kerfuffle lately over the past year and a half in regards to contracted pharmacies. So the reason why I keep our pharmacies in-house is so that way we don't have to deal with all of the extra turmoil that's going around, Because guess what? The pharmaceutical companies have had their fill of people getting 340B pricing on their pharmaceutical products. So they're trying to go after those contracted pharmacies, and that's why we stay in-house with it.
Any questions?
Thank you for your presentation. I'm a year-round resident of Manteo. I'm just checking the population in Illinois. In 2020, it was 374 people, and the population in Oak is just over 700.
Uh-huh.
How do you scale this for our needs? Because it sounds as though it works in a small population. Does the funding work for a need that's as great as ours with an aging population as large as ours?
Great question. So first of all, that is very deceiving. We're going to have at least 3,200 unique patients this year. So you might say is that what you see is just a microcosm of what we serve. And so is it scalable? Number one, it's very scalable. It's healthcare. Healthcare has always been scalable. As long as you have it in your mind, what your goals you're trying to accomplish. So there are so many patients that you can serve with any one individual provider as an example. And our model, right, we're seeing maybe 13 to 15 patients per day. In most of the other healthcare models, if you ask some of the other professionals, they'll tell you, is at least double that. So we're making sure that we're giving time and space for the patients to be able to come in. But in the same sense, you've got to make sure that you have enough providers to cover that. So my initial offering or initial kind of thought about this, right, was 2.5 FTEs, full-time equivalents, or 2.5 provider full-times, okay, that we would have in place. That doesn't mean that we couldn't scale that up. And that doesn't mean is that the building that we're looking at couldn't scale that up. So we have plenty of potential to be able to fulfill the needs of the community, of even a larger community. Hi. That's where I come into play. So, right, I came from Pittsburgh. As you can imagine, there's a much higher density of population in Pittsburgh that you deal with whenever you're talking about community health centers. Right, the community health center that I worked at, we had all told mental health, dental, and physical health. We had 21 providers. So that organization, and it didn't even serve a huge part of Pittsburgh, okay? So the business model that's been put in front of us to be able to provide healthcare services has been time tested. We know exactly how many people that we can schedule on initially, right? We know how many providers that we need. We know how many support staff that we need. And now your other part of the question, will the federal funding cover that? In part, yes, because of the enhanced reimbursement and the 340B, the pharmacy program. That does help to bridge the gap in expense because, right, especially at first, you're going to have a large outlay of cash that you're going to have to put out as an organization to hire all these people on. People start coming in the door. It takes a little bit of time to build up a practice. I mean, anybody will tell you that. So I hope that I've answered your question a little bit, but I can tell you that yes, I've dealt in larger healthcare environments. I worked at another organization, which is also another nonprofit healthcare environment that had 17 locations. We had 300 employees. We serviced 14 different counties. So I am very familiar with dealing with a larger situation. I can just tell you that I really like the community of Englehart and Ocracoke. There are. That's exactly right. And that's what needs to happen. We need to give people choice. This does give people more choice. I mean, the more services you have available, the more choice an individual has. I don't really, whenever I hear somebody tell me that they're driving to Duke because they want to see a physician, I think that that's nuts. So this is why I'm here, and this is why we're together, is to build something for the community.
Betty Jo, you had a question?
Yes, Ms. Morgan, community health centers also take insured patients.
They do.
I mean, I'm fully insured by the federal government.
Mhm.
But if I prefer a federally qualified health center, there's nothing to stop me
Yes.
from going there. And I work for Senator Richard Burr, and he just absolutely thinks federally qualified health centers are the very best health care you can get. I mean, he has been on board. He's the ranking member on the health committee, health, education, labor, and pensions. And he just touts and is always so supportive and would just really pump money into federally qualified health centers because he knows what a great job that they do. And I cover 30 counties in Senator Burr, and one of the counties I have is Wake
Mhm.
and Durham, and there are community health centers all over those counties.
Mhm.
And even in Cary's got, community health center. And a lot of it, like I said, 51% of your board, a lot of people prefer community health centers. I live in Tarboro. We have a strong Vidant presence.
Mhm.
Everything is Vidant, the hospital. We also have a community health center, Freedom Hill, that's in Princeton. And a lot of people prefer to go to a community health center. I mean, they go there by choice.
Mhm.
And there are several large, like you said, not probably like in Pittsburgh, but like Roanoke Chowan Community Health Center that has a full dental clinic
Yeah.
that is just really outstanding.
Kim Schwartz is pretty outstanding,
Yeah,
isn't she? Is. Yes.
In fact, she's the one that Senator Burr had her go to up to the Senate and testify before the Health Committee.
Mhm.
And Kim was also the first one that introduced Senator Burr to telehealth.
Mhm.
And so, it's for all people. You can have the greatest insurance in the world and you just prefer to go to that kind of, it's convenient, it's near your home, that type thing. And, I've been with Senator 18 years, and of course, like I said, I cover 30 counties. I've only known of 2 community health centers that were shut down or closed, and that was because they are
Mhm.
regulated.
That's right.
Strictly, and those people did it to themselves.
Right.
So, that's my piece on it. I know Senator Burr wouldn't mind me spouting all that. Definitely qualified.
Well, thank you very much. Yes, ma'am?
I have a question. Could you compare this to like the federal answer to a concierge practice?
Compare it in what way?
Well, in other words, a concierge practice is obviously not federally funded.
Right.
But I asked you, because I have been in those over the years, and in what you're describing, I've never heard of it. I'm from the Northern Virginia area and never heard this, and it's actually related professionally to this, but never knew about it. So, but concierge practices proliferate there. And my question is, this sounds like that, but obviously it's got the federal funding aspect to it.
Right.
Do you know what I'm suggesting?
I mean, I think so. The reason why I said that I believe that FQHC healthcare models are the models of the future is because it does just that, is that it allows you some autonomy and freedom as an organization. So, and that's a part of what concierge service does and gives. It allows you some of that autonomy as a provider to be able to provide healthcare services on an on-demand kind of basis. And so that the community health center can do that, right? But the other thing that really sets us apart is that we're able to see all patients from all walks of life. So regardless of whether you have money and you can afford a concierge service, which I could say is that might be tough for some people to do, you will have the ability to get in to see a healthcare provider without any barriers. And we can see people, whether they're on a commercial, to your point, whether they have Medicaid, Medicare, uninsured, underinsured. And it's a fantastic program. And I guarantee you that there are a lot of people that have never heard of an FQHC.
Share it with Commissioner Wickstrom. has a question.
Yes, ma'am.
I missed this, but, so you have, patients who are part of, THC, and they see their regular doctor, and he is happy. What happens if there's going to be for specialty?
Yeah, absolutely. So, I mean, this works much like a regular doctor's office whenever it comes to referrals. So let's say, for an example, that, right, because unless you're a hospital, you probably don't have all of those services in-house in any particular doctor's office. So you build through the course of referrals. And those referrals are like, let's say that you needed to go get a colonoscopy done. So you would be referred out to whatever it is facility that was either closest to you and or your pick of where you wanted to go. And that is where we would make the appointment for you and schedule that. And those results would be come back to us electronically, just like they do with just about anybody these days in regards to the EMR. So your local provider would have access to the information that you would grant them based upon whatever test or procedure that you had to have done.
And as far as payment for that, they would still be, what it was, the sliding scale. So how does that?
That's correct. So one of the things that we're able to do is that we're able to work in conjunction with some organizations. So a good example is dentistry. Dentistry is something that has been very difficult, I think, for everyone to be able to find a dentist, to get an appointment at a dentist. So what we do is that we make agreements with dentists, the referral agreements, and they basically will honor our sliding fee scale for people that are indigent. So people that can't afford, as an example, I believe, how much was it this? No. I mean, the total of that we were paying out to the dentist, 500, 550. So let's give you a real world scenario here. So you come in and you see our provider, and our provider says to you, "Oh, you need some dental work done. We need to get you to see the dentist." Well, and they're like, "Well, yeah, I can't afford to go to the dentist," or whatever the case may be. You're one of our sliding fee scale patients. You have a hard time making ends meet. So we have it set up with the dentistry that we have referrals to, whoever that might be in the local area, because that's going to be the case, that we will essentially pay for up to $550 in dental services for people that are having a difficult time making ends meet and need dental services done. Yeah, you'll pay $25 out of pocket for that. So-
Mr. Sanderson has a question too.
Just a couple of questions. When you establish or set up an FQHC in an area, is your area confined as far as service is concerned? Is it anybody can come from anywhere?
Hmm.
They're willing to drive?
No, well, you mean as far as patients go?
Yes.
Oh, no, it can be anyone from anywhere. So let me give you an idea. Right now, we currently service 5 different counties out of our 2 locations. So we have people that come from Beaufort. I'm going to say this wrong. Terrell. And Washington, Dare, and of course, Hyde County. So we have 5 different counties, thank you, that we service. And out of this location in this area, I guarantee you that we'd be doing a lot more service than just the people that are inside of Manteo, Roanoke, or even Dare County. There are going to be people that are going to come probably from a little ways away, especially if they know that we're opening a community health center. They understand the power of being able to go to these health centers and not have to dig deep in their wallet in order to be able to pay for services. So it'll attract people from other counties.
Rod, yeah, excuse me.
Within an hour, I had 4 people from Manteo scheduled in Englehart. Within
Yeah.
1 hour.
Yes, sir.
I mean, I know, according to the size of the facility and the number of full-time people that you have working, what capacities, you're limited as far as how many patients you can see in a given amount of time. There's got to be some limitation. Is that correct?
Yes, sir.
Are your patients selected on a first come, first served basis, or are some patients given priority?
Well, so, and I think it's a good question, but the way that we're to treat all patients is equal. So whenever we look at somebody, it doesn't matter what walk of life you're from. You come to us and you're looking for an appointment. We're going to set that based upon the availability of our schedule. And some people now that can change a little bit because depending upon what someone needs are. So as an example, if you come in for an annual or a full physical, that's going to take a little bit longer of a time. And so we might have to schedule that, like a week or two out, possibly, depending upon what that is and how busy the schedule is. But our wait times right now, I think, are right around 2 weeks, right? Is what our wait times are.
2 years.
So we're very efficient with being able to see patients while still spending the time that we need to spend with them based upon their healthcare situation.
Okay, Rodney, I think you had a question.
Yeah, just real quick.
Sorry.
I've often, recently, I'm wondering, and I probably should know this, the relationship between a physician and a pharmaceutical company. Is there a company that regulates that? Why does a doctor prescribe one medication for a similar medication? And is there any compensation or financial benefit for doing that?
Well, I think it's a good question, but that's not usually the consideration for a doctor to prescribe a medicine, at least from us. I can tell you that it's always had to do with, there's a couple things. First of all, if you do have insurance, there's a formulary that you have on your insurance that kind of dictates those things. Secondly, the doctor is going to prescribe to the patient what they think is going to work best for the patient.
I really wasn't talking about George. I was talking about me going to the doctor and writing a prescription out, and I think it's a druggist.
Okay.
And he says, prescribe this particular medicine for this particular problem. And there's several drugs out
Medications.
there that can treat this. Why does he choose one over the other? You may not, I'm not asking. I'm just sorry. Is there any,
Well, first of all, there's no kickbacks. No.
shouldn't be?
No, that's,
That's dried up.
I can tell you that,
That's dried up a lot.
yeah. So I can tell you right now is that we're not allowed to accept any gifts or anything from people to kind of give us a leaning in one way or another. So that's never a concern for us. As far as the actual pharmaceutical companies go themselves, what they do outside, I have no idea.
Rob, we've got two more questions, and then hopefully we can do some of this informally at the reception. Hopefully,
Malcolm's
questions are-
reception.
No, I think questions are great. The interest is tremendous. And 3 questions. Okay, Rob in the back, Beth, and Dave.
2 weeks, you said was the lead time.
Yes.
I typically see less than 2 weeks when I call my primary care physician. Now, part of I'm looking at my colleagues here because we're all scratching our heads. What if you're sick? 2 weeks?
Well, we have walk-in appointments that are available.
So I'm sick, and I want to see my doctor today.
Yeah, we usually try to fit people in. I mean, look, the reality of it is you have to balance between the walk-in service that you're going to do and what you're going to do as far as people that are scheduled. You don't want to overdo it. The idea is not to decrease the quality of care that people are getting because you want to see that one more person. So the idea is that you try to balance that. And of course, we do that. And that's a part of nurse triage. That's a part of provider looking at what the patient is. Because what will happen is somebody will call in.
Our schedule is already set during the day with the same day appointments, so already blocked every day. There's
Right.
4 same-day appointments already blocked every day on our schedule for walk-ins.
Yes. So we do that to make sure is that we have space available for people that are sick today.
Okay, Beth?
I love knowing the primary care is, because I was told 3 months out. So talk a little bit about this. This program is like what everybody would want. To be able to spend quality time with a physician is unheard of anymore these days, right?
It is.
And so I guess where I come down is, even in Manteo with the 3,000 plus of us who got the letter of welcome to drop to Virginia if you want to, right?
Right.
I feel like that you would be deluged with people as soon as the doors open. And so rather than spending time building a practice, I feel like there'll be people beating down your door because number one, they need healthcare, just flat out they need healthcare. Number two, they want this kind of healthcare. And, you know, whether you can pay or not, I'm happy to pay. And I'm so happy that that people who can't pay will be able to have an option like this. It's incredible. Why isn't all healthcare like this? But, so my big question is, I think you're gonna need 15 physicians.
Yeah, yeah. Oh, gosh, how are we going about funding? Do you want to comment on that, or just kind of, I throw a lure on the water?
We didn't hear that.
Surprise.
I don't know who she is. I can't see.
Good. Stand up, Jennifer.
That's
This
Dr. Harrison.
is Dr. Harrison. Dr. Harrison is going to be employed. She's starting with us coming this week, tomorrow. So she is from the Manteo area, and she is the first in line of providers that we will be hiring on to man this facility. You wonder where we're going to get them from. I think it's a very fair question. Well, they've been working on it. Matter of fact, I just had a conversation, a very good conversation with the people at ECU and their recruiting staff, Jennifer Muir and some of the others on Monday. So one of the things is that we need to do is to build a partnership, and that includes ECU. We have been doing that. I've been trying to work behind the scenes to figure out how we can place people, even if it's only 1 day a week, doctors that currently do work for ECU that on a contractual basis might be able to come and work for us. So that's what I've been doing, is trying to build a coalition of providers. And right, ECU is one of the best systems of providers you're going to get in Eastern North Carolina. So it's a good question, and it's a fair question to ask. The one thing that I really would like to not do is I really don't want to pull anybody from existing practices that are in the area. That's number one. Why? Because that just reduces the amount of choice you have. Yeah, that doesn't solve the problem. It just takes from one pile to another. So we need to be actively looking and recruiting outside of this area to bring those physicians in. But I will tell you one thing for sure, is that once the physicians and providers start to hear about us and start to understand the model itself, I think that we're going to have a good response. I really do.
One more question from Sheila, and then we're
Yeah.
gonna take a break.
Yes, ma'am. So,
I was curious, you mentioned 3,200 unique patients
yes.
being served now. Do you know what the current payer mix is? And are there any limitations on percentage of sliding fee versus Medicaid, Medicare, private pay?
No.
How is it structured currently in your practice?
Currently, the payer mix is, and for people who don't know what the payer mix is, the payer mix just has to do with whether they have Medicaid, Medicare, whether they're uninsured, that kind of thing, or self-pay. So our current mix is that we're about 43% of Medicare, Medicaid. We have about 7 or 8% of self-pay, and the rest is commercial. So we have a really good mix of people that we have come to the establishment.
Okay,
And
with
for the
that-
Medicaid,
oh, shoot.
Medicare, is that per member per month, or is it by CPT code, or how is the reimbursement actually?
No, that's actually on by visit.
Okay.
So there is so I'll get technical. No one has to pay attention to this maybe except for Sheila. So there's a G code and a T code that's attached to the patient's visit that's sent out as a part of the receivable or the billable that you would create for the patient. So patient comes in, they're a Medicaid patient or a Medicare patient. Once their visit is done and you send that off to billing, that is submitted through that G or T code for either the state or for the federal government to reimburse on those patients. So it's by visit. It's not capitation. There are some capitations that do exist out there. However, we're not a part of that capitation here in the state of North Carolina.
Thank you.
Malcolm, can I just say one little thing?
Uh-huh.
I just heard the lady in the back talk about the concierge service. I do, my primary position, when she left her practice, she opened up a new practice, and I went with her, I stayed with her, and I do pay, self-pay her, even though I do have Medicare, hospital insurance and everything else. It doesn't help me in the fact that if I have to get a medication or if I have to have a surgery, of course, if I've gotten sick or I've needed to come in, I've had no problems at all getting an appointment with her. But it's not anything similar to what you're saying to me right now, as far as the medical health service. But I do self-pay because I've been with her so long, and she is awesome.
You really want to ask?
Malcolm, I wanted to say one thing. Thank you so much for
Yes.
leading this group, task force.
Yes.
First, I feel, Town of Manteo, I'm proud to be part of this task force. The Town of Manteo, we have taken it by the horns, taken the lead, and we are committed to doing that for our citizens. Thank you.
Okay, we're going to take a 10-minute break, okay? So,
10 minutes.
What we need to do.
That's what I'm gonna do. We need to
you for this, and I know there's going to be more questions. Anybody here that would like to come to our office at 12 o'clock, or around 12, a bit early if you'd like, we can continue an informal conversation, because I know there's a lot of questions that people would like to ask.
And Malcolm, the address for your office is at the bottom of the agenda. It's noted as an announcement there, and there are extra agendas out on the table.
Okay, it's 300 Sir Walter Raleigh. It's my wife's office.
At what time?
At 12 o'clock. 12 o'clock. And there'll be some food there.
Yeah.
Might have to get a basket and put it in, so I hope we have enough. Okay. Randy had one more question, and I promised him.
Because I know I'll never get in line between the sandwiches and sodas and other things to ask a question. And I think others might like to hear the answer, or maybe not. This is an area that over the years has developed a robust set of charitable organizations, whether it's for mental health, whether it's for dental or physical health, to try to help people who have access issues to care. My question is, how does an organization like yours, and what's your experience in other communities, because I don't think we're unique in having it, how do you integrate what you do with their mission? Because I don't want to see a fight. That is the least productive thing I can imagine.
Well,
Even if you've got your 15 doctors.
now I will tell you is that there's never a fight in regards to providing patient services and things that people need in the community. It is very straightforward and simple. If it benefits the people in the community, we are all in for it. It might not necessarily benefit us directly as an organization. So as an example, and I think it's from Red Cross, is that where she's been getting it from, or Salvation Army? From Salvation Army. So, right, so part of the things that we screen for as an FQHC is food insecurity. I think that people have kind of heard that term a lot over the past year or two. And so one of the things is that we have a number of patients that do have food insecurities. So what we did is that we partnered with Salvation Army in Washington, and we're actually bringing food boxes to Englehart every month, and we're able to provide some food right free of charge. We bring it in. I can't remember how many we had last time, 65 or so patients that we had that actually were able to receive food boxes for free. And again, this is a free service that we do, working in conjunction with another nonprofit organization that fits exactly what it is that they're trying to do. And in turn, actually helps us out because we understand is that people do have food insecurities. So there are literally dozens of examples of things just like that that we screen for, that we talk to our patients about, that we're involved in. We do outreach. People might or might not know what outreach is. So we go to people's homes. We look at the environment that surrounds them. We are putting things on to be able to monitor blood pressure remotely in real time. So we have a lot of things that we're involved in that are a part of other organizations, okay, that we actually implement because it, melts in nicely with what it is that we do. And there are lots of examples of that. And so any community organizations that would be here, there would be no fight or struggle. It would be simple. How do we best help the community?
And, I'm sorry. That's right, too.
Second part to my question, then I'll shut up. I promise, until the next question. Obviously, when you come into a community, whether it's here or somewhere else, your practitioners need a relationship with the hospital. Your patients need a relationship with the hospital. You have a sliding scale, a fee schedule established for the services that you are providing. Could you explain how that relates to what hospitals do, or where the decisions on that would be made? Because if someone is getting a sliding scale from you is there an expectation that there would be a hospital response? We already heard this morning about some of the existing programs that the hospital has in place. And so I just would like to have some sense of your experience, because some of us may wind up in a hospital.
Yeah, and I think it's a good question. So the hospital system themselves can have programs that they have, as we know, individually for people that are indigent. However, they're not required by us to follow our sliding fee scale as mandated from HRSA. We can't require that institution to do so, and that might do undue harm to the hospital, as an example. So, however, we're able to do that with direct care providers. So, as example, as a dentistry, something we were talking about a little while ago, we're able to set up a sliding fee scale agreement with them as a part of, we're directly referring them to you as a dentist. And as a result of that, we'll pay so much dollars in care if they are on sliding fee scale. And you can also make an agreement, a referral agreement with that service as far as the sliding fee scale itself. So, in them honoring it. Now, the hospital system we could get into conversations about what that looks like. Because again, that's another financial determinant that they have to look at as a part of doing business. You know, if we refer patients to you and then we say to you, well, if we have someone that's of lower income and poverty, are you going to be able to do something more for them as far as their out-of-pocket expenses go? And, you know, again, that's a conversation that we can have in the future.
Mr. Chair, I do know Director got questions. As being on the task force, I ask that any additional questions be done at the reception, and that we make a motion and close this meeting down.
Yeah.
Is that a nice way of saying, Fenneker, shut up?
The only thing we need to do is take action on the organizational chart. If we can give 5 minutes, can you do that in 5 minutes?
Malcolm, I'm sorry, could I just say one more thing and I'll shut up, I promise.
Better, she said so.
I just want to make this to all of you. We are coming to this area regardless of what happens at this committee meeting. So regardless of what the outcome is, and I want to work with them, but just to let you know is that we're going to be coming to provide health care to this area. So just wanted to say that.
Mr. Chair,
Yes, ma'am.
to the gentleman, and thank you for everything you shared with us today. You have come to a county that you will learn is so huge in outreach. It's absolutely wonderful. And when we're talking about food insecurities, we've had a program here since 2006, Food for Thought, that feeds children every weekend in Dare County. We went from the pilot program here in Manteo of 56 children in 2006, and we got as high, Mr. Chair, as I believe 700 and some in the years that progressed.
Wow,
and now
that's
it's back
amazing.
down. And that's a wonderful thing, because first and foremost, it's about our children as well.
Mhm.
But also, it's my understanding that the community care clinic is working on a rather large initiative, for some of you that may not know it in here today, on dental for Dare County and the surrounding community. And that's something that the community care clinic in Dare is working on right now. So
Excellent.
just wanted to share that.
Yeah, and actually, that was my question, and I'll get it in really quickly with all due respect.
Okay.
I'm sorry.
I don't think there was a second. With all due respect, because I think, in follow-up to Randy's, you touched on a really good point. The community care clinic has received funding from the Office of Rural Health to set up 2 operatives, and they're getting ready within months to start construction on that. And so it sounds like there's a possibility of a partnership where you could contract with them and help, where they could help take care of patients. So I think
Absolutely.
there's, what I picked up from that is that there are opportunities for nonprofits to work together in the healthcare realm, and maybe this further one initiative from one organization to another. So it sounded like
Absolutely.
that's a possibility.
Yes. It's not only possible, but it's very likely.
Okay, thank you, Joe. I'm going to change the agenda around a little bit and let us go on into the presentation of the organizational chart, because if we can dispense of that today, it'd be good to do that. Randy, can you give us and I want to thank Randy Hamilton also in the audience, Rachel, for helping us with this.
Yeah, if you don't like it, blame Randy. Take your pick. This is a proposed organizational chart. Following the discussion, we would expect I in fact would make a motion that it be accepted by the panel as perhaps amended by discussion. And so that we would have something going forward. As you know, when the town established the task force, it appointed individuals. It did not really dictate to the panel how it was going to get its business done. I think we all know from our experience in organizations that a panel of 11 well-meaning and very talented people is not the place to get a lot of work done, and that we need some structure for control, for process, et cetera. So the one step that has been taken is the chair has appointed Mayor Pro Tem Betty Selby as the vice chair of this panel. So after the first meeting, some of us started some informal discussions. Randy has been acknowledged in that. When you take a lawyer and you take a Navy flyer / commercial pilot and put them together, can we do boxes and lines? That's what you got. And like I said, if you don't like it, blame Randy. We discussed with the chair our thoughts just on organization and structure. So there's been a lot of input by the chair. And this document reflects not only his input, but other conversations. Action item is to review, revise as necessary, and approve an operating structure. The draft is the starting point, and hopefully it is close to your end point. I would point out that the goals that are listed there are simply examples of the kinds of goals that could be short-term, medium-term, and long-term. They could be goals that were adopted, but it's really there for illustration, just clarity of the intent that we have. It's important to note also that absent a vote by the Board of Commissioners of the town of Manteo, the membership of this panel would not change. So we don't have the privilege of just saying you're now sworn in as members. And I think the chair has previously indicated that he really doesn't want to go back to the town and say, well, change it again, change it again, change it again. And I concur with that. You can see on there that several subcommittees have been established. Subcommittees are a pathway for the community expertise that is not sitting up here to be brought in. We know there are many talented people and very interested people across all of the issues that we're discussing. And so we see the subcommittees as the pathway for them to bring their expertise to bear and be reported to this group. Let me just review the structure quickly because I know he's looking at his watch. The first step is we propose the creation of an executive council. The thought right now is that the executive council would be the committee chairs and the vice chair of the panel, really working in an advisory and consultative capacity with the chairman. Any of you that have been part of a board, whether it's for-profit or not profit, know that there's an executive committee, and that is the parallel here that we see. So that would be the first. I have 7 pages to read, but I won't. We're proposing 4 committees: patient care, recruitment and retention, facilities, and project funding. Let me touch on each one of these. While each committee would have its own agenda, we would anticipate, that's what all the little arrows are for, anticipate ongoing communication among the committees as they are doing their work, so that Committee A knows what is going on in Committee B, and that there is that enrichment that would be important. Among the functions of patient care committee, for example, would be evaluating information such as has been presented today by Dr. Davies, identifying and prioritizing health needs of the residents of Manteo, Roanoke Island, and the whole of Dare County, recommendations on the number and types of healthcare providers needed to meet the medical needs identified. This is very broad: physical health, eye care, dental health, mental health / substance abuse. I think this committee would play a key role in setting much of the agenda for the Recruitment and Retention Committee and the Facilities Committee. And we suggest that we divide this as subcommittees, one on physical health, one on the mental health. So there's a focus there. We know the challenges of recruiting and retaining sufficient types and numbers of healthcare providers. Dentists, nurse practitioners, all up and down the line of the team. The purpose of the Recruitment and Retention Committee would be tasked to determine issues specific to our area that affect the ability of the community to recruit and retain healthcare providers. There are both positive and negative issues to address. I think that was amply laid out in Sheila's presentation this morning. And for those of you who haven't read all 280 pages of charts, I suggest you do. Particularly important is review of previous efforts. What has worked in recruitment, what has not worked, what new tools might we consider to add to the power of the community, all of us to pull people in. What's the experience of other communities? I think it'd be very useful to look perhaps at communities like ours, a resort community with a small resident population and a cajillion people who come in July, and see how they may have managed some of these same issues. Just one example. I think that this committee would really be looking at the human tools needed to solve the healthcare problems that are going to be identified and roll out of the patient care committee. Attracting healthcare providers at any level and in any specialty, I think also requires evaluating and identifying the number and types of facilities that we have and that would be needed to attract and retain physicians, nurses, NPs, dentists, and so forth. People need structure around them to work. What are the additional structural pieces that we would want to try to put into place regarding facilities and the services that accompany facilities? Specialty care comes up from time to time. The hospital has built out a cancer center, working on other focused areas. Do we have enough facilities for our needs? Do we need other facilities? I think a committee focusing on that aspect would be part of the structure. And finally, the task force was not given a budget. I understand there's a few dollars lying around that haven't been picked up by some other committee in Manteo, so there might be enough to pay for lunch. But we don't know if we'll need funding. But on the other hand, as we go forward, we don't know who we would want to bring in, perhaps a consultant, perhaps an academic, somebody who might need a stipend to be willing to work with us, who could add great value. It would be really up to the project funding committee to look at that need and identify resources. Those resources could be local government. I appreciate all the people who from local government who have applauded and I know will open their wallets, government wallets, of course, generously. But I think that we really need to look at that, have a way of looking at that very specifically based on the discussions and activities of this task force. When you hear that, you probably get the sense that I don't believe this is over in 6 months, and I don't. So with that, I would like to make a motion that this proposal be accepted. If there's a second, then we can open the floor for questions.
Second, duly noted second. Any discussion?
I think it's a great program.
Okay,
Done a great job on that.
okay, seeing, all in favor?
Aye.
Opposed? Okay, we've got a organization.
Now you have the job of figuring out who the people are that you can work with as chairs.
Okay, I have
I'm not
asked-
touching that one.
I've asked each person if they would chair a committee, and they said they would. Understand that this would be the executive committee, executive council, however you describe it. And Kevin Phillips has agreed to do the patient care. Randy has agreed to do the recruitment, retention, and legal services. Jim Tobin has agreed to do the facilities, and Todd has agreed to do the project funding. So that would be the executive committee of this group, and I would encourage each one of us, as their talents and interests are, to choose a committee to serve on and help out. And so we can move this forward, because I envision, I think I read Randy right, they would be doing the work and then reporting to the task force, so we can not have 2 and 3 hour meetings, okay? Just as for, and I want to thank each one of y'all for agreeing to serve in that. I want to thank again Randy and Randy for your work in this. Again, this is an example of how the community is coming together to try to help support this effort. The next thing we have is public comments. There were a lot during Joe's presentation. Does anybody from the public like to speak? Yes, ma'am, please come forward.
My name's Linda Leiser, and I am here on behalf of Lynn Jenkins at the Community Care Clinic. And as you're evaluating needs, I wanted to just give you an update on where we are, some initiatives, what's going on at the clinic, so that you can make a determination and perhaps maybe change the perception that the community clinic is just a free clinic. So currently, we are working with UNC Lineberger Cancer Center on a research project to evaluate oropharyngeal cancer. And so we already have that in place. We're working with the Harvard School of Public Health on the impact of climate change on health. And last week we had Reuters down visiting to talk to the providers on what they've been finding. We're working with ECU on the Fresh Start program, and that means they'll be bringing down mobile kitchens and bringing produce to the underserved population as well, and teaching them how to make healthier meals. And we've also just added a RN through funding to work on coordination of care, to determine or to work with patients on their social determinants of care. And she works on financial assistance, transportation, finding specialists for our patients as well. So that's already in place and working. Going forward, some initiatives that are happening. Last week we added a provider, so we're potentially extending our hours in Frisco at our satellite office. We're currently enrolling in Medicaid, and that will be up and running more than likely before the end of the year. Yesterday, we received the permit for our drive-up pharmacy, and how that's going to work is that patients from the clinic will receive medications that have been prescribed. A pharmacist will also be able to fill prescriptions for our patients that have been sent to specialists. And the Medicist program that we're currently using will still be in place for the higher end medications. As was already mentioned, we've received state funding and state backing for a dental clinic. That's currently with the architect and build out, depending on construction, possibly will be up and running early spring next year. Fingers crossed. And we also have an initiative working with the hospital, ECU physician outreach, community health workers, employers who care, and they will be approaching employers to offer healthcare at a cost yet to be determined, I think, and we will take care of their patients. And that hopefully, from the community perspective, will help with retention. And we also have a nutritional, certified nutritionist on staff as well, who is working with our patients and has helped reduce A1Cs considerably. Lynn Jenkins has offered to come and be on the agenda at your next meeting if you have availability to talk to you in more detail. Thank you.
Thank you for all the work you did. Does anybody else like to speak? Okay. At 12 o'clock, or as soon as you get there, at our office, we're going to offer some refreshments and welcome and really encourage anyone to come by, and we can have some continuing informal conversation. To the task force, I know you all are stressed for time, and I appreciate your time today. I think it was a good meeting, and really encouraged for moving this forward to help us in our community. So, a motion to adjourn.
So
To adjourn.
Second, done. We're adjourned. Thank you.